We'll now turn the stage over to Dr. Ron Liou to lead the discussion on the role of community health centers in primary care.
And thank you to PCFH for having us here to talk about community health centers today. And we're delighted. I'm Dr. Ron Liou, I'm a family physician. I get to serve as the Chief Medical Officer for the National Association of Community Health Centers. And I'm delighted to have our two guests from both coasts here today. We are delighted to have Paloma Izquierdo-Hernandez, CEO at Urban Health Plan in New York, and then Julia Liou, CEO at Asian Health Services in Oakland, California, and they'll introduce themselves in a moment. But I wanted to thank everyone for this opportunity to talk about community health centers' role in primary care, and this has been especially brought forth because of COVID and the pandemic, and I think the bringing together of public health and primary care is a perfect example of how the health centers are posed to have a really critical role and strategic role in the health of primary care and our nation. So as you know, health centers have been around almost 60 years, 58 years. They began in that setting before and really have been focused on community-based primary care setting, especially when dealing with under-resourced and underserved populations. And that's kind of our forte. Right now, health centers serve 30 million patients total, but included in that is 1.5 million people experiencing homelessness, 1 million agricultural farm workers, 400,000 veterans, and really public housing folks and people that go without care. And the joint study we just did with the AFP showed that there's 100 million patients out there that still lack access to primary care. That's really what we're about. So I want to introduce our guest today, and maybe Julia, you can start off and tell us a little about yourself and your health center, and then we'll go to Paloma.
Great. Well, thank you so much, Ron, and such a pleasure to be here. Just really excited to share that this year marks Asian Health Services' 49th year of service. So we've been around since 1974. We were started by UC Berkeley students who saw that language and affordability were the two biggest barriers to access to care for our immigrant underserved communities in California, particularly in the Oakland area. So we started off just as a small clinic with one sink. And then we are now 14 sites serving 30,000 patients and 50,000 total with managed care. And our services are medical, dental, behavioral health, and all of those services are in 12 Asian languages. We've got 500 staff, very dedicated staff, physicians, nurses, dentists, behavioral health counselors, psychiatrists, who are focused on, again, serving our underserved population. And the majority of our staff are from our diverse communities. So they reflect our patient population. And we're just, we're just so pleased that we've been able to get through the pandemic and we never closed our doors with our staff. And we're able to serve our patients, through that real crisis. So just really excited to be here. I myself, just a little background, my parents were immigrants from both Hong Kong and Taiwan. My grandfather actually was a patient of a federally qualified health center in Los Angeles, Chinatown. So really excited to be here and be part of this conversation.
Thanks, Julia. And Paloma, tell us about Urban Health Plan.
Sure, thanks. And it's great to be here as well. What an opportunity to talk about community health centers and the great things that we all do. So Urban Health Plan is also celebrating its 49th anniversary. Next year it'll be 50, which is really a milestone, especially for a health center that grew out of a doctor's practice. So my dad was the founder of Urban Health Plan, who started as a solo practitioner before Medicaid and Medicare, so a long, long time ago, and saw the need for quality, comprehensive care. He grew up in the neighborhood where the health center is located, and it's amazing how back then he really saw the need to keep people out of the emergency rooms, and so it's still the same struggle that we have today. Urban Health Plan is in New York City. We are in the Bronx, predominantly. However, we also serve 2 other counties in New York City. So we are a we are a full urban health center. We service about 85,000 people. Before the pandemic, we were at about 90,000 unique users who used our health center. We dropped down to 80. We lost 10,000 people, and we're slowly regaining them and bringing them back into care. Our visit volume, just to give you an idea, is about 430,000 visits a year. So we are a very large health center. We have 26 sites, 12 health centers, 2 mental health clinics, and 12 school-based health centers. And so the pictures that you'll see here are really how involved we are with the community. And I think that that's one of the foundations of our health centers, is that we're very community-based, grassrooted, and really speak the language and the culture of the communities that we serve. So let me stop there.
Yeah, sure. Thanks, Paloma and Julia. And just a little bit about myself to round it out is, as I mentioned, I'm a family physician. I practiced in a rural community health center for 20 years in Central California, working with agricultural workers and their families. And I think I did about 1,000 deliveries. So it was a very busy practice, really enjoyed it and loved it. So that's kind of where we're all coming from. So moving on, I think people want to know about health centers, and we have some requirements and things that are really important. And one of the bedrock requirements of a community health center is that they must all be governed by a local board of directors that includes the majority as active patients. And so how does this feature root your work in the community? And we'll start with you first, Paloma, and then Julia.
Sure.
But how does that community board fit into things?
Sure. I think one of the coolest things about a community health center is the consumer board. When you think about it, and I say this to all the new staff that come in when I speak to them at their new orientation, is our health centers, we're required to have at least 51% of our board be patients, be users. Therefore, and I say this, the patients are the ones who are in charge of approving our budget, approving our policy, hiring me, evaluating me, and firing me. And I think when I say it in those terms, it really rings home the importance of our patients and who they are and what their role is in the health center. And I think that's an empowering thing for the patients as well, to be able to sit at a table where they usually would not be a part of and really have their voices heard. And I think that that is the power that our consumer boards bring forth. I wanted to bring just an example of one of our board members that we recruited. She was a patient actually in our HIV clinic, so chronic illness, and very nice woman, and has been now on our board for many years. And she came in as a very quiet person, somewhat intimidated, because I think sometimes they are. Even though they're among their own peers, I think just being at that table is a little intimidating. But slowly developed her voice, and we started putting her on a co-chair of committees. So she now chairs one of our committees. She's actually now the secretary of our board. And now she's moved up from a clerical position that she had in the community to now she's one of the managers at the voter, whatever they call it, county voting system. But it just really shows how selecting someone who's nice, bringing them on, working with them, developing them, not only empowers them to have a say in how their community health center is run, but also shows the professional development and the personal development that goes on for each one of them. So I think that that it's such a unique feature, and really one that really separates community health centers from every other healthcare system. And it's one of those invaluable, really good things that sometimes is not viewed as so good by other health systems, but that adds just that much value to the work that we do.
Great. And Julia, what are your thoughts about our, community board members?
Yeah, I think to build on what Paloma said, I mean, our patient involvement as board members has really been such a bedrock to all we do. Our mission at our health center is around dual pillars of advocacy and services. In fact, our mantra is that our measure of success is not only in the number of patients that we serve, but also the number that can assert their right to healthcare. So as Paloma has said, a voice at the table means everything. And our patients, having them at the table is incredibly valuable. So we manifest that through our patient town hall meetings. So this is a picture. It's a little bit like Model UN. And so we gather, 400 to 500 of our patients together in one room. They speak 10 different Asian languages. We have simultaneous interpretation, but it is about kind of participating in democracy. They come from countries where they were punished for actually speaking out. And so this was a way for us to actually establish platform and a vehicle for our patients to have a voice. We bring our electeds to these meetings and so that they can hear directly from our patients. And at the same time, our patients can hear what is happening sort of on the public policy landscape. And just to tell a story, one of our, patient town halls, we had one of our Vietnamese patients and he stood up and he said, "How can I have good healthcare without good teeth?" And that was our impetus to start our dental clinic. And so really, I think taking that input on the ground directly from our patients has really been so valuable in really shaping our healthcare and services to the needs of our patients. And we really feel like we manifest that through multiple levels. We also have patient leadership councils. And so we establish those so that we have, again, another level of community involvement. We hold those on a monthly basis in our different languages that our patients speak. And those are actually little microcosms where we can actually get feedback from our patients around what they actually want to learn. And then it's an opportunity for us to also be bidirectional and share, these are some, health education topics. And so it just becomes a great opportunity for us to, again, engage in many different ways. And very recently, we brought all of our patient leadership councils together to really celebrate their different cultures. So coming across from Vietnamese to Korean to Cambodian to our Filipino and Tagalog communities all in one space. It was just an opportunity for us to, again, come together, but hear also from what our patients are thinking and also to raise, again, their voice to the table.
Great. Thank you for that texture and detail of the consumer board members. I think it's really critical. And myself, as I got to attend the board meetings because I was the chief medical officer, I had great interactions with the board members. And I think the balance of having that 51% or more as consumers is critical to keep us focused. But I also appreciate the other 49% who are usually made up of professionals from the community. It could be healthcare people, bankers, attorneys. We've had all kinds of folks involved. And I think my favorite combinations are I had one board member who was also my patient who I delivered 2 of her babies. And that was extra special because there was a relationship there and a trust where she could tell me and say, "Hey, Dr. Yi, I waited an hour and a half in the waiting room. What's with that? Can you help me with that?" And so I appreciate that accountability that we have. And she was a teacher also. So she was actually in the education system and brought some great input to the board meetings of like, "Hey, can we do this for the community? Can we help them?" So I love that combination of what the health center model has created of the professionals, but also the consumer board members who are majority, but then those combination ones that are both professionals and consumer board members. So that combination, I think, really is outstanding to me. It holds us accountable, but also gives us that insight into really what's going on in the front lines. So thank you for that detail. Community health centers were established in the mid-1960s, and we've enjoyed 50 plus years of bipartisan, bicameral support. And this has really been critical for us. So my question to you all is, what role have federal investments played in the growth of the program? And how does your health center leverage federal dollars to meet the growing demands in communities that have been traditionally under-resourced and disconnected from primary care? So I'll start with you this time, Julia.
Well, Ron, I think that community health centers have really been such an incredible backbone and really infrastructure for our safety net and for our Medicaid population. So those federal investments have been critical. They've been critical for our sustainability. And as you said, it's been important for us to be able to actually leverage those dollars. We've used those federal investments to expand our services. So we were able to establish new medical, new dental clinics, and then also a geriatric center of excellence. But with those dollars, we're able to then go to our foundations, to our cities, to our counties, to then actually amplify those dollars and be able to support and really invest into our community and serve the needs, because we just are finding constantly there's that increased demand for our services and for primary care. And so I think it's been incredibly important to be able to, again, leverage those dollars and actually just to kind of, look at we have a consortium of clinics in our region and our county. We have 8 clinics that serve a total of 300,000 patients. And when we look back at, what we did with our federal investments, we've actually been able to save the healthcare system $537 million. And actually, when we look at Medicaid dollars, that's $433 million. So when we look at really what we're doing, we're actually not only serving our most vulnerable, but we're also being able to save our healthcare system significant dollars.
Wow, great. Paloma, how about you? How about these federal investments?
Sure. So just to piggyback on what Julia said, I think that the amount of money that's put into federally qualified health centers is never the voices are never loud enough to really talk about the value and the cost savings that we produced for the system. We are really we're the largest primary care network in the country, and we produce, Ron knows better than me, the number of overall savings that we produce. And yet I hate to say this because I don't like it. We're always mentioned as the best kept secret. And after 58 years, I know I don't want to be a best kept secret after 58 years. I want everyone to know the great work that we do. So I really hope that that's one of the messages that we bring, that the federal investment that goes into community health centers really produces not only cost savings, but very, very good health outcomes for the 30 million people that we serve. In terms of our own health center, so we weren't always a federally qualified health center. We're 49 years old. We became federally qualified about 23 years ago. So we spent a lot of time not being federally qualified. And I remember when we first became federally qualified, not only did the money that we get go to support all of the primary care services that we have provided, and we did provide a lot of multi-specialty services at that time. All of that is supported. But it went beyond to really, and so our involvement with a quality improvement effort, an initiative that was taking place back 20 years ago, we participated. And through that, we were able to transform our organization by what we learned in that quality improvement initiative, that it has totally transformed no lie. This is truly transformative. And I know that transformations take 10 to 13 years to actually take place. It's happened in our health center, and that would not have happened without the federal involvement. But in addition to that, when we became federally qualified, we had 2 sites, maybe three little sites, and through the ARA money that we got, the American Recovery and whatever reinvestment money they had, we had already planned a new facility and lacked the financing. And so when the funding came out, we were shovel ready. And that's what they wanted, was shovel-ready projects. And so we were able to build a 36,000 square foot facility that now has expanded with federal dollars to be a 96,000 square foot facility. That's our main site. Without those federal dollars, we would never, ever have been able to do that. So I can look at federal investment from what it was like without it and what it was with it. and to really say that it has given us increased access to capital. It's allowed us to increase our services, like our HIV program we've been part of the HIV initiative. So we've been really able to expand those services. So not does it only support what you do, but it really allows you to get that money. And one of those projects, those construction projects, we were able to take the federal dollars and leverage it for new market tax credit financing, which produced enormous savings to us. And it was just an enormous project for the community. So through those community investments, you also get the ability to hire more people. So you really become an economic engine in the community. So it's not only the federal investment in your regular services, but the ability that it allows you to continue to grow and really influence that economy in your communities.
Wow, that is so good. And it's so encouraging to hear the details of how you have saved locally funds, but then also on your side, Paloma, to take those as investments. It's real seed money from the federal government. And then you've multiplied that looking at tax credits and different ways to use those funds to really serve the community. So I think that's the goal, I think, of this federal funding, is to really not pay for everything, but get us going, get us stimulated, help us to think creatively of how we have a bigger impact for our communities. You know, we have this big challenge coming up. September 30th is when we need to have reauthorization for our health center funds. So I appreciate our staff at NAC and you all from the field of contributing to giving input to our congressional members, because that vote is coming up, really critical for those 30 million patients that we serve right now. So thank you for being on the front lines and for being wise stewards of the funds that we've been given. So we've heard today about workforce. This is a huge challenge. It seems like every single conference we have and meeting, this is the top of the list of the discussions. But, you know, how to address this workforce shortage in primary care is really top of mind, as I mentioned, at all these meetings and industry leaders. And really, this has gotten more acute in previous sessions we just heard about people leaving, retiring, quiet quitting, all these things going on. And we've appreciated President Biden proposing significant funding to beef up the National Service Corps, teaching health centers, nurse corps, and behavioral health workforce development. And recently we had many hearings on this topic, but more health centers are looking to grow their own or develop apprenticeships and pre-apprenticeships programs with high schools, 2- and 4-year colleges to expand the pipeline of workers. And so how are you addressing these issues today and preparing for the future? Both of you have done some pretty extensive work. Can you share with us what that looks like? We'll start with you, Paloma.
Sure. So our workforce right now, we employ 950 full-time equivalents. 175 of them are providers. And we have about a 10% vacancy rate. So we're only staffed 90% capacity. That 10% is composed of not only physicians, but nurse practitioners, PAs, nurses, social workers, case managers, receptionists, medical assistants, and the list goes on and on. The pandemic has just really played a big role in how people look at jobs and where people want to go. In our community, we have a huge increase in crime. So people don't necessarily want to come into our communities, and the ability to work remotely, as the previous panel mentioned, has really impacted that ability as well. I would say that we have more nurse practitioners and PAs than we have physicians in our facility. And I was just telling our chief medical officer yesterday that we have to learn and create a plan for treating those doctors as gold. And how do you use them in a way that really leverages the nurse practitioners and the PAs in a way that you're not working at a deficit, but you're actually leveraging those doctors to make it of a different healthcare delivery system, right? And and you have to rethink how you do that, because just putting people in exam rooms and having them see patients, that doesn't work anymore. And especially with social media, we have a huge social media presence, so everyone sees all the great stuff we do out in the community, and then the providers come in and you stick them in a room to see patients all day long, and people with comorbidities, and it burns you out. It really does. So now we're thinking, how do you give people some service time back so that it actually makes it fun, and they could actually reconnect with what they originally thought they were coming into, right? So all that stuff is really important. We have a lot of partnerships with training programs. We had to stop them all. The pandemic really, as you all know, really threw a lot of stuff in the holes, or whatever you want to call it, but it's made it difficult. But we're regaining those partnerships so that we could offer internships to our medical assistants, because we have to kind of create those pipelines to get people in. They come in, they see what they like, they want to stay, and that's kind of how you really have to think about this. We offer tuition assistance, and we have moved quite a number of medical assistants to nurse positions, which is very, very helpful. We are very active in the National Health Service Corps. We have 43 National Health Service Corps participants. I think we're one of the largest sites in the country. Of those 43, 9 are doctors, and we also have 4 J1 visas. So those visa programs are critically important as well. And sometimes there's always a chopping block for visa programs and how many visa people you could have at one time. Very important. We also have become a nurse practitioner residency program. So we now have, I think we have probably about 10 nurse practitioners that have gone through that program. Again, a great pipeline for creating and retaining staff. And we just got our first teaching health center planning grant. So we're really happy about that. But I think it's really putting your heads around this issue and being flexible and changing the number of hours that people work, or the number of work days that it just takes a lot of strategic creativity in thinking about this and how you get it right.
That's great. Thank you. So what's going on at Asian Health Services, Julia, on your workforce side?
Yeah, I think that a lot of what Paloma said, I mean, thinking about how do we be creative during this time of workforce crisis, because we know that COVID fatigue and compassion fatigue has been very real. And so how do we address that? So at Asian Health Services, we're very excited. We also got a planning grant as well. So we've always been looking, I know at the last panel, sort of the teaching health center, that is really what we would like to aspire to. But I think we look at, the big T, and we're sort of trying to work our way in sort of the small T. So how do we look at the ways to sort of build from where we're at? So sort of the small T, so we have a planning grant. We're going to do a dental residency program. We just saw that the needs for oral health, and we know across the country, even all of our, federally qualified health centers saw that, as well as, the primary care aspect and behavioral health. But we're really excited to be doing that. We're going to be opening a new dental clinic and starting that residency and having 4 dental specialties. So we're one of the few in the state that have both a dental program with 4 specialties. And we're really excited because we also are, launching a mental health academy. I'll talk a little bit more about that, but really that is how do we look at sort of these internships for our MSWs, because it has been so challenging to hire licensed, clinically licensed social workers. And who speak the language. And so we recognize we're going to have to start the pipeline earlier. So that's where we're starting right now, is with these MSW interns. And we're really excited because we've just trained about 10 of them through this program. And again, I think it is about what you said, Paloma. It's about building that pipeline, because we have to be creative and you have to invest, but that's kind of a long-term, we have to do that now. And so we're sort of planting the seeds. We do have a nurse practitioner program that we started I think it was about 5-6 years ago. And similarly, we're seeing really the investments come back because people want to stay. They learn about, the community health center. They get to know our patients and really are invested in the mission. And so we've seen, a great retention rate. In fact, our 2 new graduates from our nurse practitioner residency, they're staying. So we're very excited about that. But I think it is about, growing your own. And I think that's the investment that we need, is to be able to create that infrastructure, because what we're seeing is that we have so many of our folks who are coming from the community. We have to create that career ladder. So we're looking at that also from our MAs, trying to create sort of these health coach ladders. We're even thinking about how do we build in digital health coaches to address digital divide. So we're trying to be really creative. But I think it does take investment. But I think that's what the beauty of being a community health center is, because we can be innovative, creative, and try and pilot things. And again, sort of leverage those federal dollars to, again, enhance, where we see and address the needs of our community.
Yeah, thank you so much for that creativity. And I love the grow your own, because, previously we talked about diversity in the workforce, and having folks that look like the communities they serve is critical. So if you can find those people with the mission and the heart, and then teach them the skills they need, that's the best case scenario. So thank you so much for those examples. As we look at the early days of community health center movement, they came out of not only addressing patients' medical needs, but really looking at social, emotional, physical, and housing needs. And Jack Geiger, the father of health centers, is known for prescribing food for malnutrition. And I think along that same thought pattern is really these social drivers of health that we work with every day, that health centers have worked with for decades. But can you describe how the health center's commitment to the philosophy that health involves more than just healthcare, but how do social drivers of health continue to manifest themselves at your health center? So, Julie, I'll let you go first on this one.
Great. Thanks, Ron. Community health centers, we've always been addressing, social drivers of health. And I think that we've been addressing it since the beginning, even before, social determinants of health became a term. And I think it's really something that's embedded in our DNA, and especially at Asian Health Services. And I'd like to sort of tell a story. When we were opening up our second dental clinic site, our chief dental officer had brought numerous sort of issues to the forefront, and all of our dentists were seeing a lot of patients that were, talking about suicide. They talked about domestic violence. They were facing a lot of depression, and our chief dental officer said, "We don't know how to handle this. This is an increasing need that they're seeing of mental health issues, especially with the pandemic." And so she said, "Well, I think we actually need to create a new model." And so we now have a dental and wellness clinic that integrates both dental and mental health care, so that now our dentists do depression screenings. And they're able to now, if a patient is in need of mental health services, we can actually have a warm handoff right in the dental clinic. We were featured in the San Francisco Chronicle, and the title, I think we have a picture here. It says, "Are you lonely? Are you anxious or depressed? Maybe your dentist can help."
Yeah.
And so it's really been this new model and approach to, again, thinking about mental health on so many different levels, because our dentists really just didn't know. They didn't have the skills. They weren't trained to do this. And so it's really been an incredible sort of model for us to be able to do that. And I think that, again, providing mental health support at every juncture has been critical. I wanted to talk about also that, with the pandemic, we saw our mental health visits increase almost more than double. And I know that was a trend that was across the country, but in particular for our community and our patients, when COVID hit, it was not just COVID, it was actually also our patients and our staff were being blamed for COVID because they were Asian. And so our staff were spat upon, attacked, our patients have been assaulted. So when we saw our mental health visits, again, skyrocket, we saw that, again, these anti-Asian violence incidences in our own county increased by 300%. So as a response, what we did is we actually created a community healing unit. And this community healing unit is really focused on trauma-informed care, because a lot of our mental health practitioners haven't been trained to address these types of incidences. I think, Paloma, you talked about increasing crime. The same thing was happening in our community. And so a lot of our staff were very afraid to come to work. Our own patients, our seniors, didn't want to leave their home because they were feared for being attacked because of their own race. And so we created this unit where we can, it's in all the different languages that our patients speak. And so they're able to access this unit. And it's, again, trauma-informed care, but it's also about navigation and support. So they can actually make a phone call. We have folks who can then navigate them to the appropriate resources. They can help them fill out a police form, because it's usually in English, and understand how they can access the, again, resources, whether it's food assistance or transportation or whatever those needs are, because they faced, again, it could be a violent situation, or again, they're afraid to leave their home. And so this unit we've created, now we've become one of 3 pilot action centers throughout the nation addressing racism. And I think that, again, we've seen now as racism has become a public health issue, and it really is around sort of social determinants of health, and we think about how we're providing our health care. So I think that, again, this community healing unit has been incredibly important for our community, and we've expanded it not just to our patients, but also for our community members. This is a picture of our community healing unit, and now we've expanded it so that we're thinking about health and healing, especially as we're really recovering from the pandemic. And it's really just been such an important force in our community, and just a really testament to our staff who really pivoted and have been nimble to be able to respond to these type of needs and issues.
Wow. Thank you, Julie. And I think that's just shows such a responsiveness of Asian Health Services to really what's going on in the community, not only with community members, but your staff. And so appreciate, your work on this community healing unit, what we can all learn from that. So how about the social drivers or determinants of health over at Urban Health?
Sure. So as I mentioned, Urban had been involved with this quality improvement project through HRSA for many years, and we have built dashboards that really track our health outcomes. And so I remember one day looking at these graphs and saying, wow, this is really phenomenal. We're really good health outcomes. And then I remember looking and saying, but everybody's life is exactly the same. And it made me think that it's not about physical health, and it's so much broader. And how do you actually start approaching those things in a systematic way? The way Dr. Geiger envisioned it when he started the entire movement. So we started out with, we had a health literacy center that had been licensed, funded by the Office of Minority Health. And for some reason, the funding was no longer available to federally qualified health centers, but I had a lease. And so I remember saying, let's do a community needs assessment, because I don't like when you lose a grant just shutting things down, especially in a community that sends a very wrong message. So we said, let's just do a community needs assessment and see what people want. And there were a bank of computers in the Health Literacy Center, which, by the way, was not successful. The Health Literacy Center, they were not interested. People were not interested in health literacy. But there were a bank of computers there that were always busy. So I said, well, what are they doing? What are they doing on those computers? And so between the community needs assessment and the computers, we recognized that what people were doing was looking for jobs. So we said, okay, well, how about if we take this little space that was already leased out, and why don't we convert it into a workforce center? And so we went and hired a workforce developer who is still there now. He's there about 12 years. And we now run, it's called they changed the name. My name was Project Hope. They changed my name. They changed it to Bronx Workforce BX, Workforce BX. And what they do there is they do high school equivalency training. They do English as a second language, citizenship classes. We run OSHA classes, so people are prepared for construction jobs. We do prepping for resumes, job interviews. We manage when people get jobs, how long they keep them. So we've become a fixture in the community as a little storefront. We do job fairs twice a year. We have local and we recruit for lots of employers. So that was for me a way of addressing the financial driver, because I think that the biggest way you solve this, right? If you think about this, the biggest social driver is poverty. That's like fundamentally it. You could color it, you could paint it whatever color you want, but at the end of the day, it's poverty. So how do you get people out of poverty? And one way is jobs. And then we became very ambitious, and God bless my dad, who at the age of 80 decided that he had been active in the American Academy of Family Physicians. He was grandfathered in. He was a pediatrician, but he said his kids grew up and then he became a family doc. He had gone through the cultural competency training that the AFP had done a long time ago. And he recognized and he knew the stats about the number of physicians that were of minority descent and how many of them became physicians. So we started a charter school. And so we have the Dr. Richard Izquierdo Health and Science Charter School, which there are our graduates. We started in 2010. It's a charter school from grades 6 through 12, with the hopes of and he always said, there's going to be a shortage. At some point back then, we knew there was going to be a shortage, and shame on all of us for not doing anything back then because we knew it was coming. But he said, by the time they get it all together, let's create our own pipeline so that we could create our own healthcare workers. So we have now part of our program is that there's an EMT component. So kids are able to qualify and graduate with an emergency medical technician certification. So it allows them to work while they hopefully move on to college. We also took over the local Economic Development Corporation. So we work with local businesses. The largest food distribution center in the country is located in our community. And so there's lots of jobs and there's lots of opportunity and there's a lot of money. So that money has to circulate through our community. So the idea has always been to try to improve the financial picture of our patients and our community, and so that we could slowly get them out of poverty. The other big piece that was kind of laid on us during the pandemic was the lack of food and the food insecurity that our patients were just coming in and they just didn't have enough food. And so with the help of the largest food distribution center in the country and our local elected officials, we've been able to run weekly food distributions. And we don't want to call ourselves a food pantry yet, but that's what we've become. And then what we found was that entities had toiletries and they had diapers and they had all kinds of stuff and no way of distributing them. So we took all that stuff on and we're now opening a storefront for that purpose. So slowly you recognize the needs that are in the community and you strategically kind of figure out how is the best way to achieve them. And as the largest organization in our community, I feel that we have a social responsibility to really meet the needs beyond healthcare of our patients.
Wow. Thank you for really bringing some detail and texture to the social drivers. What does that look like to address those? And thank you for doing that. So finally, we know addressing America's primary care challenges really can't be accomplished in silos. We need partnerships. So what role do partnerships play to ensure our most vulnerable communities have access to timely, high quality, culturally and linguistically appropriate care in their own communities? What have you all been doing with that? Paloma, we'll start with you.
So I think that I think when you look at partnerships, it's easy for us to think about partnerships because of the deep roots and who we are in our communities. So we have those deep rooted, very strong ties into the community, and having healthcare so close to home is so critically important. I think when you look at healthcare and its delivery system, and the fact that we're in the community makes the biggest difference. So we have partnerships with hospitals, the food distribution world, with just we're just one big intermingled network. The one partnership that I really do want to highlight is we created a local community coalition, and I co-founded it with another partner who I kind of said, this is a good idea, don't you think so? And it was right at the time that President Trump was elected into office, and we knew that funding might be affected. And so we wanted to assure that all of our resources in the community were maximized and were used the best way possible. So we pulled together the community-based organizations in our neighborhood. We pulled them together. We called them. We started out with a small group, maybe 5, and now we've grown. Just yesterday, we had a meeting, and we have 30 community groups that are part of the coalition, and we have been meeting every month for 7 years, with really the goal of advocating for each other, building upon each other's strengths, maximizing our services for each other, and with the hopes of really improving the quality of life of the people in the area. We've been successful. We've gotten elected officials funding for the program, so we've created a 15-year vision for the community that we did jointly. And right now we're in the midst of creating a community dashboard, so that we could track really important indicators for that community, so we could actually see how the community is advancing, and how we could align all of the work that's done by so many people in a community around those indicators, so that we could really think about moving that needle in terms of poverty and quality of life. I think the biggest thing that we've accomplished is developing trust, because without a trusting partnership, there's no basis for a partnership, right? So we have to all learn how to trust each other, which we've done very, very well.
Thank you so much. Julie, what are some of your key partnerships?
Yeah, I think, just kind of building on what Paloma said, I think because we're just such trusted institutions in the community, and just being able to serve as a hub and a convener, I think that, one of our key partnerships has been around this mental health academy. And we're doing that partnership with Kaiser. Now, Kaiser has been an entity that sometimes a little competitive, because our staff end up working at Kaiser and they're recruiting away. But, we've also been able to build sort of these partnerships where actually we're working with Kaiser to pilot this sort of innovative model, again, around sort of MSW interns, and be able to build this pipeline. What does that look like? Because, again, there's so many needs within the community for addressing, again, some of these issues that our patients are facing, and again, building that pipeline. So I think, again, these partnerships are very important to look at, even though they may be your competitors, and how do we work together? I think it's an incredibly important aspect to be thinking about. I think that also partnerships with our city and with our county are incredibly critical as well. When we saw that pedestrian injuries and accidents were highest in our local neighborhood, we actually worked with our city council members. We actually worked with the Chamber of Commerce and we worked with our Bay Area Rapid Transit to develop what was actually a safer environment for our pedestrians. So we actually got physical capital improvements done to creating safer streets. We actually tried to look at community identity, pulling together community town halls, working with architects, working with engineers around what do we envision our neighborhood to be and how can it be safer for not only our pedestrians, but also for our patients who are coming to our clinic in those neighborhoods where those pedestrian accidents were happening. So I think overall, again, these partnerships and diverse partnerships are so important, and being responsive to the needs, because we can't do it alone. We had nail salon workers who were experiencing a lot of health impacts, and we had to create a coalition to address that because of the chemicals that they were handling on a daily basis. So I think there's so many opportunities, again, to build across and think creatively around what does getting to where we need to look like, and it involves more than just one entity.
Yeah, thank you so much. Great examples of partnerships. And I do want to reference and remind folks of just the critical role that health centers have played with federal partners. You've mentioned local partners, but I think on the state, federal level, we've also had some great relationships with the CDC, HHS, HRSA Administrator Carol Johnson, the Bureau of Primary Health Care, the Bureau of Health Workforce, CMS, Congress, and really state Medicaid directors. Those relationships the health centers have helped them to understand really what's going on the front lines with Medicaid and how to administer those programs. So I think that just really brings forward those relationships, not only locally, but federally, that are really critical. So I appreciate your time we've had here. I can't believe it's gone by so fast. Really, thank you for just bringing the detail of really what community health centers look like and their contribution to primary care on the front lines. I think you've done excellent jobs with your work locally, but also contributing on a national level. And so thank you so much for Asian Health Services, Urban Health Plan, all you have done in really carrying on that legacy of the health centers after 58 years. So thank you again for time together. And any final thoughts? I'll give you the last minute or two.
I think I don't know where in the discussion or what forum this works in, but I think what became very apparent, at least in New York, when the pandemic hit, was the fragmentation that exists in our healthcare delivery system. And for us, it was, and I think for all health centers, and resources were put into the hospitals. And New York, as you recall, was like the real epicenter in the very beginning. They were put in the hospitals and they needed to be there. But we were totally forgotten about. We were just, the federal money was slow in coming. We were just left out there to hang. And we were the ones who were stopping the floodgates from more people going into the hospitals. And that was never recognized. And I think at some point in time, there needs to be a discussion, whether it's local, state, nationally, that our healthcare system has to be coordinated. Because without that coordination, it's more expensive. People don't get better; they get worse. And for me, my mantra lately has been access to timely care. And it doesn't matter whether you're in an underserved community, if you're in a wealthy community. I think access to timely care is a major problem in this country, and how we fix that. So we could talk about primary care docs, which are really important. But at the end of the day, there needs to be a look at this entire healthcare system and figure it out.
Right. Final thought, Julia.
Okay, try and do this in 10 seconds. I think it's actually really imperative to be able to look at what are some of the innovations and also the work that community health centers have done on the ground, just to your point, Paloma, during COVID. So being able to sustain those and scale those up, I think that CMS really has that opportunity, and thinking about, again, how really community health centers have been so critical to primary care. High quality primary care it should be a common good. So I think that community health centers should be really brought to the table as part of that discussion in what does that system look like? Because we're really going to be part of that discussion around what does the future of community healthcare look like?
Great. Thank you, Paloma. Thank you, Julia. Thank you for Primary Care for America. Thanks for joining us.